Thank you. Thank you very much for coming back on time. If everybody can take their seats. Now I know how a ringmaster feels. I need a chair and a whip. That's what I need. Great. Thank you very much, everybody, for coming back for our second plenary session. Just a reminder to those online that I hope, as you've seen from our first session, questions are coming through to us, and we will put them to the panelists and plenary speakers as we move forward, and now as we have opportunity. So thank you very much for keeping to do that, and we hope that that makes you feel engaged and involved in our sessions as we move forward. It was mentioned in the last session, actually, about the critical and growing both evidence base and concern about microplastics and their impact on health. And that's something that we at Healthcare Without Harm Europe have been pioneering with hospitals here in the UK, including Great Ormond Street. We've got to stop mentioning them, haven't we? And others across Europe. So I'm delighted to welcome one of the main stars of our programme managers working on that, Josephine Frame, and she will introduce the panellists ready for our next section on the Born Green generation.
Good morning. Welcome to this session from Baby Steps to Big Impact in Maternity and Paediatric Settings, Born Green Generation in Action. So, as has already been mentioned, we're dealing with quite an intense heat wave today, and one of the health risks associated with extreme heat is very close to the hearts of the panel here today, because during pregnancy, extreme heat can increase susceptibility of developing gestational diabetes. It can increase risks of problems with fetal growth, placental function, increased rates of preterm birth, and that all increases pressures on maternity services and can result in additional NICU admissions at birth. And that requires more care, more resources, more consumables, and more plastics. And even in London, the climate, the heat risks, as well as the health risks of microplastics and associated chemicals, disproportionately affect the most vulnerable, the socio-economically deprived, and global majority ethnicities as well. And the healthcare sector is the largest consumer of single-use plastics, and last year a publish from Systemic and Eunomia estimated that if we continue in a business-as-usual model to use single-use plastics, then across North America and Europe, by the time we reach 2040, we'll be responsible for almost 30 megatons of carbon equivalent emissions, and that's approximately a third more than today. And 3/4 of those emissions are generated upstream, so the sourcing of the materials, the processing, the manufacturing and transportation. And then microplastics, as well as their physicality, the presence in the body, early evidence is finding that it is now affecting placental function, which also leads on to those complications I mentioned. Many of the devices, plastics, contain endocrine disrupting chemicals, which can impact hormone production and function, which childbearing completely relies on. So, in partnership with 4 European care providers, Born Green Generation launched in 2023 to reduce the reliance on plastics across maternity and paediatric settings by eliminating unnecessary plastics, introducing circular healthcare practices, and using safer materials. And this shift in practice also reduces a baby's exposure to these chemicals during their formative first 1,000 days, from conception to their second birthday. And as mentioned earlier, we want to do this because prevention is key. We want to prevent diseases from happening rather than treat them. So today we're going to hear from 3 of our clinical partners about some of the initiatives they've launched and how they are being scaled and replicated, demonstrating that high quality, safe and effective care can be delivered with fewer plastics to our most vulnerable patients. So we'll shortly hear from Imogen Stringer, Nurse and Born Green Generation Implementation Manager at Great Ormond Street here in London. And then we'll welcome Sina from Lundoft, Midwife and Born Green Generation Project Manager across Region Midland in Denmark. But first, I'd like to welcome Ali Kimber-Herridge, Midwife and Born Green Generation Project Manager from Newcastle upon Tyne NHS Trust.
Good afternoon, everyone. Mesdames, Messieurs, bonjour. Sorry if you're not French, can't speak any other languages. So as Joe mentioned, my name's Ali. I'm a midwife. I've been a midwife for many, many years. I'm leading the Born Green Generation project in Newcastle upon Tyne. As most of us know, the National Health Service is one of the largest consumers of single-use plastics in Europe, operating theatres representing one of the most significant tributors of that use. So they generate up to about 67% of a hospital's total waste. This presents a substantial challenge for us as we're trying to deliver high-quality care whilst reducing environmental impact. In Newcastle upon Tyne, we've taken a practical step towards addressing this issue. We've introduced a more sustainable approach to surgical skincare preparation within our obstetric theatres, which has been led by the Born Green Generation team. So traditionally, surgical skin preparation, so that's the cleansing of the skin, the operative area prior to incision, that was done using gauze swabs held with a reusable stainless steel forceps, dipped into a solution of 2% chlorhexidine in 70% alcohol. This is commonly known as the swab on a stick method. So over the last few decades at Newcastle hospitals, the swab on the stick has been replaced with the single-use plastic applicators, which contain exactly the same antiseptic solution. However, these devices are a lot more complex than they initially appear. They contain plastic, they have a glass vial within them, which holds that solution, and there's a foam sponge for application. Manufacturer data is very limited, but we estimate that each device contains about 10 grams of plastic, but that could be more. Born Green Generation team raised the question, is this reliance on single-use plastic devices really necessary? Particularly when a neighbouring NHS trust less than 15 kilometres down the road, as well as others, have been continuing to use the swab on a stick method perfectly safely. When we first proposed reintroducing the traditional method, the idea was met with understandable resistance, particularly from senior perioperative nursing staff who raised concerns about patient safety. So to address these concerns, we adopted a structured quality improvement approach using the Plan, Do, Study, Act, the PDSA model, to gather the evidence to demonstrate that swab on a stick could be introduced in a way that protected patient safety whilst also reducing our reliance on the number of plastic devices in our theatres. So we began by engaging key stakeholders early, always important, including infection prevention control, procurement, the perioperative safety and quality group, and our obstetrics clinical board. Undertook a literature review to identify any guidance on the optimal method of skin preparation, and very importantly, found no evidence or guideline mandating the use of a single-use plastic applicator. Across all of the literature, 2% chlorhexidine in 70% alcohol was consistently recommended as the first-line agent unless contraindicated. However, the method of application was very rarely mentioned. World Health Organization advises application using sterile gauze and instruments, moving from clean to dirty areas, allowing the solution to dry completely. NICE recommended an alcohol-based chlorhexidine, but did not specify the particular device. And our own trust guidelines, very importantly, did not dictate how we should be applying this chlorhexidine. So based on the evidence, we developed a standard operating procedure, working alongside a consultant anaesthetist and obstetric consultant colleagues. So the SOP that we developed addressed the risks that had been raised by the perioperative team. First of all, fire risk was mitigated by controlling the volume of solution used and ensuring it dries fully before any incision to the skin. And medication safety risks were addressed by strict timing and removal of the gallipot immediately after use. Importantly, the doctors are never ever allowed to hold this bowl of chlorhexidine to avoid any temptation to possibly pour it on the patient if there's any left in the pot. And we're pouring out the same amount of solution into our gallipot that is used within the plastic device. So clear procedural guidance has ensured consistency and safety in practice. So our first PDSI cycle, we initiated a pilot using swab on a stick for elective caesarean sections only to allow staff to become familiar with the technique. Staff were asked to complete evaluation forms after each procedure. Feedback was largely positive. However, clinicians reported that solution lacked sufficient tint, making it difficult to visualise the skin coverage. So we paused the pilot. We sourced an alternative solution with a deeper tint. So that was the end of PDSI cycle 1. So cycle 2, we reintroduced the technique using the improved solution. Feedback was significantly more positive. And at this stage, the Director of Infection Prevention and Control requested that we undergo some surgical site infection surveillance before and after the implementation. So 2 of our resident doctors have gone through notes and that they've done this evaluation. And the results of that demonstrated that post-implementation, infection rates were comparable to the baseline, confirming clinical safety. If anything, there was a very slight reduction in infections with a swab on a stick. So result of that, on the 15th of June, so last week, good timing for this, we implemented swab on a stick for all our caesarean sections. So none of them will be done using the single-use device. We'll be using the swabs for all of them. So the impacts of this. So it delivers impact across 3 domains of environmental, financial and clinical, as well as a broader benefit for our people. So environmentally, the single-use applicators, which we were previously using, are made in El Paso, Texas, over 8,000 kilometres away. Whereas the chlorhexidine solution that we're using with a swab on a stick, that's made in Thirsk in North Yorkshire, which is 112 kilometres from our trust. In addition to reducing the number of devices requiring manufacture with the health risks associated with plastic production and a reduction in plastic waste, this significantly reduces transport-related carbon emissions and supports more localised procurement. The financial benefits, each single-use applicator costs around about £7.20, whereas in comparison, the swab on a stick costs about 50p per procedure. So that's a 93% cost reduction. And in the current financial climate, that matters. The plastic usage is also dramatically reduced, around 10 grams per applicator to about 4.2 grams, we think, per caesarean section. That's based on the use of a 200ml bottle, which we can get, we can do 6.5 caesareans with a 200ml bottle. We have to dispose of each bottle at the end of the day after 24 hours of opening, but we never really dispose of many full bottles because of the amount of caesareans that we do. Reducing plastic also has workforce benefits. So operating theatre staff are exposed to microplastics throughout prolonged occupational exposure. So reducing this plastic consumption will help to minimise this risk and contribute to a healthier working environment. And within maternity, a lot of our staff are of childbearing age themselves, so that's really important. Clinically, really crucially, patient safety has not been compromised. The antiseptic solution remains unchanged, and infection surveillance, as I've already mentioned, has demonstrated equivalent clinical effectiveness compared to the single-use applicators. So, in conclusion, long-standing practices should not just be accepted because that's what we've been doing for ages. They need to be re-evaluated, and we need to question them in light of environmental and financial pressures. This project has demonstrated simple, evidence-based changes can deliver meaningful impact without compromising patient safety. Between April 25 and March 26, our trust performed 2,166 cesareans. If this sustainable method had been used for all of those cases, we could have avoided 3 tons of carbon dioxide equivalent emissions, and the trust could have saved about £14,000. That's just within our obstetric theatres. So the Born Green Generation work that we've done for this highlights that sustainability and high quality care aren't competing priorities, but they can and they must go hand in hand. The potential ripple effect of this plastic reduction intervention is enormous, as it could be applied throughout surgical services across our trust and wider than that. Oh, back to Imogen. Thank you very much.
Hello, thank you so much. It's going to be a hard stint to follow. Thank you, Ali. So I'm Imogen, and as Joe introduced me, I'm an intensive care nurse by background, and I'm from Great Ormond Street today. And I'm going to be talking about one of our BGG initiatives. When Joe proposed the sort of format of today's session, it was really tricky to work out which one we were actually going to focus on. And I think at first glance, what I'm going to be talking about today is about our medicines. And when you talk about medicines, it might not necessarily seem that sounds like a sustainability or plastic reducing initiative. But when you actually start looking and drilling down at the wider impacts that actually has to our patients, our staff, our resources, the wider environment, we can really see how a relatively simple change, if we really drill down to it, can really create quite significant benefits across the hospital. And I've chosen medicines again today because I think, as from an ICU nurse perspective, when I came into this project, plastics was on my remit, but I hadn't really thought about some of the wider paradox that plastics really creates and in that decision making as a clinician. And I think for me, giving blood transfusions was part of my day-to-day life. And you think our most vulnerable patients that would be presented to me, the ones that are most vulnerable would quite often heat up that blood so that it wouldn't be less of a shock to the system. But actually in doing so, we're hanging a blood which is in a plastic package, is then being infused via some plastic giving sets into a plastic cannula going straight into the patient's vein. And we're heating that up, so we're actually increasing the leaching of microplastics going into that patient. And I guess that's something I really reflect on when I'm kind of talking about this sort of project that I'm going to be focusing on today. So we really looked at the prescribing practices when we're looking at our medications to really fit it into the direct impacts of the Born Green Generation sort of opportunities. Not because we wanted to reduce treatment, not because we wanted to save money, not because we wanted not because we wanted to save money in that respect, but we really wanted to ensure that patients were receiving the right medicine at the right time via the right route. And in many cases, this is really about identifying opportunities where we could clinically appropriately swap the administration route. So ideally going from an IV administration to an oral therapy much sooner. And to explain the problem a little bit more, so for every unnecessary IV that we give, we know that it's not just the IV. We're not just talking about the medicine here. That is a plastic cannula. It's the giving set. It's the pumps. It's the nursing time. It's the waste disposal. It's the transport. It's the procurement and everything else that then is the indirect consequences, potential infections that the patient might get from having these invasive devices. So they might be here for a longer time. All of this adds up. So the team and one of the key leaders throughout this is sat in the audience here today, Nicola, did some incredible work about what this challenge actually looks like and how the data could be done to actually really sort of drive this. So Nicola looked at one of the most used medications across the hospital, which is paracetamol. So I'm sure everyone in this room has probably taken paracetamol themselves at some point, and looked at about how the current practice, so she chose one ward to do the auditing of. So audited the administration routes that were being done. It was a neurosurgery ward. Reviewed the clinical presentation of the patient. So what are they presenting with? Can we be giving that paracetamol in a different way? We know that some patients have to have IV. That is their clinical presentation. That is the best decision to make. they might be sick, for example, they might have sepsis, a fever. The IV is the clinically indicated route. But sometimes we go to that and then we forget to keep reviewing that, and they might be on an IV for a much longer period of time, and actually we could have swapped to oral sooner. Or is it something that we know that we've got a nice, easy giving access point, so we're going to go for IV because in our minds that might be the quickest thing for us to do, but actually is it the right one for the patient? So reviewed a lot of the clinical presentations and then assess the opportunity for administration. So really looking at, can that patient actually be swapped from what the IV administration that they have? And then the very laborious bit of then measuring all the plastics that are associated to each type of administration, and measuring the nursing time. And I think this is the bit which I have to say I think is really really unique in being able to capture the nursing time. I think that's one part that I'm going to touch on a little bit later on. And then using all of this data to guide the change and measure those outcomes continuously. And I think the challenge that I've put on the slide there, it's just a few of the parts. There's probably loads of bits in that sort of administration procedure that I've forgotten, but it really does show you that it's not just, I can't just focus on one product here, like Ali's been able to give the breakdown of where each one's come from, because there's so much involved in medication administration. But as a result from doing this on the pilot ward, there has been really broad impacts. And I think it's really key to break this down into different ways that it's accessible to the audience that you're presenting to. So if it's going to move along. So the financial benefits, obviously this is one that quite often talks when we're trying to get projects on the ball. But I think from this, the scale up of Nicola's work on the pilot ward has been able to show that there was an avoidable 14,000, nearly 15,000 avoidable IV medications. So almost half of those could have been swapped to oral. And this also then shows if we were able to swap those to oral, this would save 48 days worth of nursing time, which is huge if you really kind of account for that. If you think of the times that we don't have staff on board and we can't justify that bank or agency spend, if we're freeing up 48 days, that you can really start talking for yourself for being able to invest in initiatives like this. And then there's a total annual cost, which certainly speaks for itself on this slide, almost £100,000. And this is just looking at paracetamol, remember, on the ward. But environmental, we're talking about born green generation today. So this is one of the key bits that's to be focused on. So up to 360 kilograms of PVC plastic could have been avoided. And that's just looking at some of the direct bits. If we're looking at medical equipment, it could go a little bit further. But also there's a carbon footprint that's associated, and we've also got reduced clinical waste and reduced transport and supply chain. That's all associated to that. And then socially, we also know that being able to move from an IV to an oral medication also has a lot of patient and social benefits. That patient who might be tied to the bed space, might be frustrating that they can't leave the bed. They are suddenly given a little bit more autonomy, especially when we think about discharging that patient home. Can we change some of these medications to a tablet? Think about even if we were to move it from liquids to tablets. There was a case study from GOSH recently where they were looking at some of the cystic fibrosis patients. Generally, they wanted to go on holiday, but they had done a lot of work about could they swallow pills and tablets, which is something else that's been a real key part of the broader look of this project. They were suddenly able to get through security in no time at all, whereas that used to be a laborious task. They were there hours before. Holidays were a stressful experience. So actually, if you really look at the day-to-day life of the impacts of this project, it really starts showing the impacts for a child, which suddenly has been granted some independence and autonomy and some potential, allowing them to integrate in more normal day-to-day lives of simple activities of going on a family holiday. But also then has fewer cannulation-related issues. So we're looking at reduced infection rates and IPC sort of ideas. And again, there's the pill swallowing. So again, sort of really pushing on that autonomy section of it. And I think I'm slightly going over time a little bit. But what I really wanted to say that this project, this is in its infancy. This is on one ward with one medication, and if you think about that's what that can do in the fact that we've got the impacts there that I've just discussed, it's not just financial and plastic reduction, it's the wider benefits that brings indirectly to the patients. But then that communication of it, so the amazing things that can be written up that people can then get excited about. They can see that that's a decision that's in their autonomy. And me as a clinician, if someone said to me, okay, what's one thing I could do tomorrow morning after hearing Imogen speak today? I would say, okay, right, next paracetamol administration I'm giving, I can ask myself for 1 second, is this the right route for that patient? And if I can do that, that's taking me 1 second to think about it. But that's something that everybody can have in their path. To be able to question, do we even need this in the first place, which is such a core fundamental of Born Green generation. And then that then ripples into the sort of the hospital change and cultural shift. So as a result of Nicola's work, it provided the sort of real boost to be able to get something, to be able to show the need for UMaker. So we've been able to get now the carbon footprint associated to our medications. Hopefully now, fingers crossed, to hopefully, wait to see, but on our EPIC prescribing, so that when a clinician actually clicks onto that medication, they'll be able to see not only the cost, but also the carbon footprint. And if it wasn't for that sort of influential bit, we probably wouldn't have had the investment from the board and the financial investment to get that over the line. So that's to be confirmed, but yeah, something really exciting that shows that that ripple effect really does have there. So I guess to sort of summarize what I've been talking about there. I've talked a lot about reduction there, but perhaps most importantly, when we're creating a culture where optimization is, we really want it to be viewed as not reducing something, but improving something. And I think that's something that we should really take away when we're thinking about what we do. And Born Green generation certainly isn't about asking clinicians to choose between quality and sustainability. It's about showing that the best clinical decisions can really be the most sustainable ones. So yeah, thank you very much.
Hello, everyone. I think I will be the only one holding the time because I will do it short. Okay, because I would also like to talk to a little about what we in Denmark have experienced, that a local network across hospitals has really made a difference when it comes to scaling and speeding up the spread of initiatives that reduce the use of plastic and unwanted chemicals. Thank you. I will also share a few concrete examples of initiatives where the network group has helped roll out these efforts more broadly. Okay, I have to start by giving you just a bit of context so you can understand this. Because I represent the Danish partner in the Born Green Generation project. In Denmark, it is not a single hospital participating, but the Central Denmark region as a whole. The Central Denmark region is 1 out of 5 regions in Denmark. Within the region, there are 5 hospitals with maternity and postnatal wards, and 4 out of our hospitals also have a paediatric department. So here on the map, you can see the hospitals. The region has around 1.3 million inhabitants, and approximately 15,000 children are born here every year. I've had the pleasure of working here as a midwife for nearly 15 years. So I have contributed a little bit to the birth rate myself. Because of the size of the Central Denmark region, many clinicians here meet new families every day during the first 1,000 days of a child's life. When the Born Green Generation project started, a lot of our clinicians were already working with sustainable solutions. Because of that, we saw a need to bring that knowledge together and to create better opportunities to share experiences across departments. So what we did was that we established a local network group within the project. That's the group you can see here. Today, the group consists of 16 clinicians from maternity, postnatal, and neonatal departments from all 5 hospitals. The purpose is to support knowledge sharing across hospitals and help scale the solutions that are already working well. In that way, the group also helps drive a cultural shift, spreading best practices and building a shared ambition for healthcare without unnecessary toxic chemicals and single-use plastics. The group meets every 3 months, either online or in person, and we rotate our visits between the different hospitals. This provides an opportunity for clinicians to share knowledge about Born Green Generation initiatives through different presentations, peer sharing, and the development of personal relationships and communities of interest. It also allows our clinicians to gain first-hand insight into how the initiatives work in practice, as they can see and experience the solutions in real-life settings. Okay, I'd just like to share a few examples of how our collaboration within the local network group has helped scale initiatives that reduce the use of plastic. And that's what I've tried to illustrate here. One of the initiatives that all members of the transfer group, or the local network group, we call it a transfer group, have worked on is reducing the use of examination table paper in pregnancy clinics, maternity wards, and paediatric departments. Although several departments had already started this effort before the Born Green Generation project, the project has really helped accelerate the process and expand its implementation. At some hospitals, management has simply made the decision to completely phase out this examination table paper. But at other departments, it has been necessary to work step by step, convincing each department that it is possible to eliminate it without compromising hygiene or patient safety. Our local network group has played an important role in this process by providing inspiration, motivation, and mutual support, demonstrating that phasing it out is both feasible and impactful. At Aarhus University Hospital, which is the biggest hospital, examination table paper is no longer used during pregnancy or after birth. And as a result, the department saves nearly 500 kilograms of plastic each year. And in addition, they reduce waste by 1.6 tons and carbon emission by 7.8 tons. And that's just one of our departments. Okay, another example is how the network group has helped reduce the use of disposable changing mats in our neonatal units. Because what we saw was that when families were transferred from our largest and most specialized intensive pediatric department to the smaller hospitals, parents would often ask for plastic changing mats. That was simply what they had become used to during most of their hospital stay. So when this problem was raised within the local network group, an initiative was launched to reduce the use of disposable mats. And it had a significant impact because one department reduced its use by more than 90% in less than a year. This means a saving of around 325 kilograms of plastics every year. At the same time, our smallest patients' exposure to plastic during their stay. And there's an important co-benefit here, I think, because by limiting the use of disposable products in the hospitals, we also show new parents that reusable alternatives are possible. And we believe that that can have an effect on their own habits even after they go home. So this was just 2 out of many examples of how our local network across hospitals has helped us scale the Born Green Generation initiatives. Thank you very much.
Thank you, Tina, Imogen and Ali. It has been an absolute pleasure working on this project with yourselves and the wider team, and of course our team in Angoulême, Dominique, who's the implementation lead but couldn't make it today. And this is only 3-4 examples of what has been implemented. There has been a significant amount of work that has been achieved right across the for organisations as well. And there's still more to come, but from the data that we've got today, the changes that have been implemented have annually eliminated over 131,000 plastic devices, most of which are single use. They have removed 7.6 tonnes of plastic from even entering into their respective wards, and collectively have saved over €250,000 in procurement. And as I said, there's more to come. They're still working. There's still things that they haven't gathered the data and reported on yet. So it has been an incredible journey to be on over these last couple of years with these teams. And it hasn't been easy. Although it's impressive, it has not been easy. And essentially liaising with each of the team, there has been consistent themes of problems, challenges, and also enablers that have cropped up. And yeah, despite regional differences, national differences, there has been consistencies. And from that theme, essentially, we have then built an implementation toolkit. So this is to help guide new hospitals through also adopting Born Green Generation principles, and incorporates resources such as change management leadership theory, an assessment tool to help identify and prioritise which plastic should be addressed first, some communications, stakeholder engagement, resources, and a lot more. And then this has also helped shape the development of a fast follower programme. And our first fast follower cohorts are about 2/3 of the way through the programme, and I've spotted at least 2 people in the room today. And this is a series of workshops to help guide teams through the implementation toolkit to adopt Born Green Generation initiatives locally, and also building a community amongst clinical teams as well. And in addition, we have also had interest from 22 organisations from around the world. So it really shows that there is a clear appetite to reduce healthcare's reliance on plastics, remove harmful chemicals from care settings, and adopt circular practices. So before we move on to questions, if you would like to join the Fast Follower programme, the QR code on the right will take you to the registration form, and the QR code on the left will take you to some further information, some more of the initiatives that have been implemented, and you can register for our newsletter as well. So I'll leave that up while I open the floor for questions. Oh, lovely.
Hi, thank you for that. That's really inspiring. I wondered how you communicate these changes with your families and what kind of reception you get.
Yeah, sure. I think generally the positivity is actually more so than you'd think. I think a lot of the time when you're creating or you're looking at your driver diagrams to work out how you're going to approach it, I think as ourselves are the biggest barriers, we're thinking of perceived problems even more so. And actually, when we've done some of the projects, we haven't received any of the sort of negativity or minimal negativity from what we'd thought. And I think one of the examples of that, I'd say, from Great Ormond Street is we did one of the UK's first pilot of using glass infant feeding bottles. And part of it, I know Nicola and our colleague Alice did some surveys of parents to find out how they actually felt about the glass bottles, and is it a change you'd want to see in hospital, all of those kind of things. And it was actually resoundingly positive. There was only positive things to be said. Yeah, we'd preemptively thought before there was going to be a lot of sort of backlash, but actually it was really positive, and actually they wish they could be using glass more. So yes, I think a lot of the time when we thought about how we communicate with parents, it's just being able to have that honest, open conversation to say, you might see the patient in the next bed space having something different, but that's because we're trialing this because of this reason, and we've got the evidence stacking up, we've got the weighted evidence to really support what we're doing. And actually people are really sort of quite almost as from my experience, there's always almost a sense of relief from some parents to be like, oh, the responsibility is not mine. I don't have to make this decision. The healthcare service that I'm in and trusting are making that for me by taking some unnecessary plastic and toxins away. I personally yet haven't received any negative bits when I've been having conversations with parents, which has surprised me. I'm sure that will come, I'll touch wood. But no, thank you for that question. I don't know if anyone else wants to.
And Ali, I know that at Newcastle you prepared and developed some patient information resources as well.
Yeah, a lot. I have to say, a lot of the changes that we've introduced at Newcastle are kind of almost behind the scenes, so they're not particularly patient-fronted. But feedback from people is basically, I think that awareness is growing outside of this project. People are becoming more and more and more aware of the harms of plastic and the need to reduce microplastics. So generally, the changes are being received positively of those that the patients are aware of. As I say, a lot of the stuff goes on behind the scenes.
Great, thank you. Any questions online?
There's no questions online, but a lot of love for the panelists. Thank you. All great ideas, great initiatives. Thanks for everything.
Yeah, we've got a question over here, if we could have a mic. Yeah, just from behind you.
Hi, my name is Margot. I'm from Epic, our Bristol office. Very impressive projects. It's so exciting to see. I was wondering, either from the Born Green Generation perspective or from your individual organizations, are there plans to scale up? We've talked about scalability today. Are there plans to scale up either within your hospitals outside of pediatric or maternity units, or for Born Green Generation to look outside of those units as well holistically?
Do either of you want to talk frontline experience?
The skin prep for surgery, there's no reason why that couldn't be scaled up further. We actually had a presentation with our chief executive from the hospital the other day, sorry, acting chief exec, and he was very much, we see this, why can't this go further? So hopefully we can. Once we've had a little bit of time to prove that we're not actually going to see a big spike in our infections, that things are going to carry on, there's no reason why that couldn't get scaled up throughout the hospital for surgery.
And yeah, essentially, so part of the scale up, the glass bottles, for example, that's an initiative that was launched in our French partner, Angoulême, as well. So that's something that they have already adopted. When we did a site visit, took inspiration, was like, can we do it back home as well? So there has been those kinds of scale and replication inspiration. And then, yeah, similar, some of the other initiatives that have been implemented have initially focused on like the maternity, the neonatal paediatric wards. But as Ali has just explained, they've gone, let's do it in the rest of the service. Let's do it in the rest of women's health, or right across the hospital. So seeing some things, medicines, waste management. We've got examples of like placenta boxes downstairs that Newcastle have switched to cardboard. Also sharps boxes that they're not exclusive to the setting. So it's great to see that inspiration that has come from Born Green Generation, having that service-wide change as well. Yeah. We'll just make this the last question before Sam gives me a glare.
I'm Eileen from Philips, and first of all, thank you for the great presentation and the inspiration. I have a question about the impact slides. I really love the stats, very much solid, right, on the environmental side, on the financial side. But I'm curious if you could elaborate a little bit on the health outcomes and the patient outcomes. I can imagine it takes a little bit more a longitudinal study, but any first insights or directions that you see emerging so far?
I knew eyes were going to come to me, mostly for that. So that's out of scope of the project. We have been focusing on the implementation. We know of within the science and the academic community, there has been various studies that have also looked at the reduction of exposure and the more a case of health issues that arise from exposure. So therefore, mitigation would mitigate those health risks as well. But that actual health consequence, the research around that, we know that would be a huge, significant financial avenue as well, and we wanted to focus on making the change. Okay, so I will wrap up. By all means, we are all available on Who Below. We will be downstairs on the Born Green Generation booth, so please do come along if you have any further questions or ask online. And yeah, we continue to invite you to continue the discussion and feel free to connect. And again, please join me in thanking our panelists today.